I think I have 8 o'clock here, so why don't we get started with tonight's Journal Club. I'd like to thank everybody for taking the time to tune in for this version of the Next Generation Editors Journal Club through ASJ. I hope everybody's doing well, keeping healthy. My name's Ryan Austin. I'm a plastic surgeon here in Toronto, Ontario, and I've been serving as the lead of this NGE section. This is our second Journal Club. And I'd also like to introduce Miriam Saheb Al-Zamani, who's a colleague of mine and a fellow NGE from Mississauga, Ontario, just down the road. She's going to be moderating the chat box tonight. And so make sure that you keep your chat feed open, follow along, answer the polls, feel free to ask questions, make comments during the presentations, and we'll try and get to as many of those comments as we can throughout the course of the evening. So for those of you who are regular ASJ Journal Club attendees, you'll know that 2 months ago, we set a record actually for attendance at the ASJ Journal Clubs. And then that record was immediately broken last month with last month's Young Aesthetic Plastic Surgeons Journal Club. So I'm happy to report that everybody's tuning in. Everybody seems to be enjoying this forum. And I'm hoping that we can keep that trend up tonight. We had fantastic registration numbers for tonight's Journal Club titled Optimizing Breast Pocket Irrigation, the BIA-ALCL Era, from the June 2020 issue of ASJ. And we're lucky to have two great discussants here tonight who need no introduction, but I'm contractually obligated to give one anyway. So first up, we have the senior author of this month's article, Dr. William P. Adams, Jr. Dr. Adams is a graduate from Vanderbilt School of Medicine before completing his residency in plastic surgery at University of Texas Southwestern Medical Center in Dallas, Texas, where Dr. Adams now maintains his private practice and also serves as an associate professor of aesthetic surgery at UT Southwestern. Dr. Adams is not only the program director of the UT Southwestern Aesthetic Fellowship, but he also recently became president-elect of the Aesthetic Society. Dr. Adams is an international authority on aesthetic breast surgery, and he has worked throughout his career to advance the science behind breast implant irrigation solutions. So we're lucky to have Dr. Adams out with us tonight. We're also fortunate to have Dr. Julie Khanna here with us tonight to provide her insight and expertise, and also hopefully make Dr. Adams sweat a little bit. Dr. Khanna is a graduate of the University of Ottawa Medical School, and she completed her residency in plastic surgery at McMaster University in Hamilton, Ontario. Dr. Khanna is a past president of the Canadian Society of Aesthetic Plastic Surgery, and she currently serves as the Canadian member on the Judicial Council with the Aesthetic Society as well. Dr. Khanna has published an ASJ on her experience with aesthetic surgery and aesthetic medicine. So thank you so much, Dr. Khanna, for being here tonight as well. With that being said, I'll hand the screen off to Dr. Adams for his presentation. So please take it away and everyone enjoy.
Great. Well, thanks so much, Ryan and Miriam and Phaedra for putting this together. Really appreciate ASJ asking us to present this at Journal Club, and I've done one of these again about 6 months ago, and just fantastic. So it's a great forum. I hope everybody enjoys it. The paper here, you can see the paper just published in print. It was published last fall online. Just as a means of disclosure, really I don't have anything to disclose other than this was an ASURF study. And I've been researching and developing expertise in this area for about 20 plus years and have a real passion for it. So we feel very fortunate to have been able to publish this in ASJ, being the great journal it is. I just wanted to say a couple things about my co-author. So Dr. Eric Culbertson was my fellow in 2016 and 17. And he did the lion's share of the work in this study. Actually, believe it or not, as a plastic surgeon, Eric spent a lot of time in the microbiology lab, plating things and doing a lot of the methodology. And he was integral, actually, in the data that you see in the paper. Anant Diva has been a long-time collaborator and research partner of mine. I met him 20 plus years ago. Also a keen interest in bacteria and biofilms. And David Greenberg is my collaborator at UT Southwestern, and he is an infectious disease doctor and microbiologist. Great guy, world-renowned, especially with regard to biofilms, and it's been fantastic having him as a collaborator for some of these studies. So Let's, what I'm going to do is just briefly go through a little bit of the history in this paper, and then I think that Julie, I've known Julie for a long time. She's a fantastic plastic surgeon, great educator. I think that she'll be able to discuss things. And then I know Ryan and Miriam will lead a great discussion, so I hope you enjoy it. So, I got into this 20 years ago when I was a resident. It was 1996. People knew about the subclinical infection of capsular contracture, but most people kind of felt it was staph epi was causing the problem. And what we've learned is that it's really a polymicrobial problem. It's really not just one bacteria, but all these different bacteria you see listed were implicated in the formation of capsular contracture. And therefore, if we're doing things in the operating room, we want to be able to cover or minimize the bacterial load of all these different bacteria. So when in 1996, I was working with these respected faculty of mine, and it was just kind of a peculiar situation because all of them were using various different antimicrobial breast pocket irrigations, including, hey guys, can you hold it down? Sorry. All of them were using different breast pocket irrigations, but really had no rhyme or reason why they were doing so. So things like tea-colored betadine. I was from the South and knew a lot about tea. Like that didn't make any sense to me. Double antibiotic solution. That was another. That was the one I actually liked the best. And the funny thing was the nurse basically was that whatever 2 antibiotics a nurse could get her hands on that day was a double antibiotic solution. So I kept asking questions, and finally Fritz Barton, I think out of frustration, said, hey man, you just need to go to the lab and you should study that. So we did. So we took this to the laboratory, and we did a lot of different studies. This is starting 20 years ago, and this was the first of the ones where we described betadine triple, but it was really this combination of either irrigations or components that would cover all these different types of bacteria that we were worried about. So not only staph epi, and by the way, we found that all those single agents that you saw other than straight betadine that my faculty were, didn't work even against staph epi, let alone these other bacteria that we were worried about. And so through our studies early in 2000 and 2001, we described 3 recommended antimicrobial breast pocket irrigations. You can see them here. We had betadine triple, and then non-betadine triple antibiotic, and then 50% betadine. And those were the 3 solutions that were recommended. They had the most polymicrobial activity, and subsequently in our clinical study, we demonstrated 10 times lower capsular contracture rate using those antimicrobial breast pocket irrigations. But we weren't the only ones that were looking at this, and actually these findings were very similar. So you can see below, Tom Weiner, who I think is on this call, published some fantastic studies using 50% betadine. He also showed a 10 times lower capsular contracture rate. A Finnish study by Giordano also showed a 10 times lower capsular contracture rate using these solutions, and a study out of Michigan had similar 10 times lower reduction. So many different researchers have found, come to the same conclusion. So getting into this study, 20 years later, many surgeons have used these different antimicrobial breast pocket irrigations, but in the era of breast implant ALCL, the question was, do these irrigations work against what most experts believe is a bacterial trigger for this disease? It's really hard to refute that when you look at the wealth of the data, the distribution of cases, the case clusters, and it does seem to be a shift in the gram-negative microbiome that is causing that transformative host response with breast implant ALCL. So the question was, do these irrigations work against these gram-negative bacteria? And then there were some other potential new irrigations, chlorhexidine, Irricept, hypochlorous acid, silver gel, that we also tested. And we used a standardized technique, and we varied concentration and contact time, which is basically the standard of how you would test these type of things. This is a table from the paper, but again, just in a high level, we looked at bactericidal activity, So bactericidal was anything greater than 3 logs reduction, which is kind of the standard 99.9% reduction of bacteria. So anything greater than that was considered bactericidal, and anything less than that was non-bactericidal. So you can look at this chart. It's fairly busy, but basically the blue is bad, and the darker colors are good. I've kind of summarized that data here, along with some other things. We've looked at what with these different antimicrobial breast pocket irrigations are approved around breast implants, standard dilutional testing, such as we did in this study, protein soil testings, wound healing effects, long-term effects of breast implants, being off the shelf, something that you don't have to prepare and cost. But you can see the green, the more green, the better, and the more the red, the worse. So in our study, we really found the betadine containing irrigations to be superior, particularly with the gram-negative bacteria. The last thing in this paper that we talk about is really some of the urban legends, and there's been many over the past 20 years, certainly, that I've heard and have been brought to me, and we address them at the end of the paper. So I just thought it's useful, I think, because a lot of people have questions about this. But in terms of betadine dilution, when we say 50% betadine, just so there's no confusion, 50% betadine is basically if you take the stock solution and mix it half and half with saline, that would be 50% betadine. Remember, betadine or povidone iodine is then 10% povidone iodine and 1% available iodine. The other thing that comes up sometimes, people say, well, betadine is non-sterile. I would say the outside of the bottle is non-sterile, but betadine, povidone iodine is an exceptional antiseptic. Actually, there's no known resistance to betadine. We've never cultured anything out of betadine solution or povidone iodine solutions. You can actually get sterile preps of betadine. This is just down the bottom here. This is from Medline. It's a skin prep kit. You've all seen them. It has little sponge sticks. It has 2 bottles of sterile betadine, all prepackaged in a sterile container. The reality is what we use is single-use bottles. So the outside of the bottle is not sterile, but it's just prepared by the nurses and mixed in the operating room. Quadruple, that's where people were getting confused about betadine triple and thinking that had different antibiotics. And so they were really using non-betadine triple antibiotic, which contained bacitracin, gentamicin, and cefazolin, and then adding betadine to that. But we've tested that. It doesn't really add anything to the original solutions. And then there's kind of the new girl in town effect, or these different things that come up, but irrigations that don't have a lot of data behind them. And sometimes people find those appealing. But again, none of those really tested well in our studies, and also others done by other people. And then lastly, just remember, it's about, we're not going to completely sterilize a breast implant pocket. It's about bacterial load, relative bacterial load, or net bacterial load, and threshold. And those are what give you the end result. So in conclusion, there's really no magic bullet. It's not one thing you can do. It's kind of the net effect of all these different things, but the details do matter. And so I would leave you with really follow the science. The science is always the best way to deal with these things. So follow the science. There's actually been 31 studies now that support, number one, these antimicrobial breast pocket irrigations, but in this study, we found the betadine containing irrigations to be superior. And do remember, there's consequences when you don't do that. And I can just tell you anecdotally, I have friends, people I know that have been part of some of these case clusters. For example, someone that uses bacitracin irrigation only that we showed 20 years ago doesn't work even against the most common bacterias. And they have 3 cases of ALCL. And I know some others have used just cefazolin irrigation, and they have multiple cases of ALCL. So, when you don't follow the science, then, there is consequences associated with that. And again, these antimicrobial breast pocket irrigations are really just one part of the whole 14-point plan. That's not anything new, but, we've been educating on that for many, many years. beware of the urban legends, and then remember, it's really the net bacterial load that we're worried about. So we can use these betadine-containing irrigations to try to help minimize that load, but there's many other things that we do as well that impact the outcome of the patient. And with that, I'm going to turn it back to Ryan and Julie, and thanks for having me present.
That's great. Thank you so much, Dr. Adams. That's a fantastic review of an excellent paper. And so I'd love to hear Dr. Khanna's thoughts and any rebuttals, questions, concerns, or issues.
You know, one of the things that when I read this paper, as always, Bill, you do a great job, and you're very scientific and very clear. But this was something that was really bothering me about ALCL for a while when I first heard about it, you know, in 2015. And if we look, and many people on this call are too young to remember this, but we had betadine taken off the market, or we were banned from using it because of integrity of the implant. And I really felt that that had something to do with the subsequent uprise in seeing cases of ALCL with textured implants. Because if you look at when textured implants were introduced, especially in North America, you know, 1999, I put my first 410 in, and we lost the use of betadine around 2001. And I think that lingered for a while, even though we know, what year did it change, Bill? That I think it was around
2017.
17. But
Yeah.
I think people held on even longer for not using it, and they didn't switch so easy. And I really wonder if it was just a double-edged sword, that we got into this situation because we were told not to use a product because of that. And I really, that was something I firmly believed in. And I also was quietly off-label using it in 2000, even at, or 2001, I started using it right away when I went to my own clinic. They wouldn't let me do it in the hospital, but in my own clinic, I said, you guys are wrong. And I kept going because it didn't make sense. Because most of the integrity data was about injecting an implant. So I don't know, I think we really saw this uprise in ALCL. I think that might have been a big component of it. And your data is also going in that direction as well.
Yeah, I mean, I think that's certainly feasible. I do think that there are many surgeons, at least in our kind of survey of surgeons over the years, many surgeons were using betadine off-label. Certainly if they were using, say, the non-antibiotic triple or non-betadine triple antibiotic, that also had excellent activity against these gram-negative bacteria, albeit it took longer contact time, so you didn't want to dilute your solution out with some technique things that you can do. I think the other thing that plays a big role in just why we saw these cases is because bacteria have evolved over time. You know, we know this from many other areas of medicine. Bacteria 20 years ago weren't causing issues, and 20 years later, the same bacteria are causing issues in ICUs and all sorts of device-associated infections. So bacteria have evolved too, and I think sometimes, you know, the knee-jerk response is certain things. If I have a case of ALCL, it means I'm a bad surgeon. Not at all. There's a lot of factors. There's patient factors. There's genetic factors. There's bacterial differences across the world, and bacteria have evolved. So, you know, you just do the best you can do, but it doesn't mean that you're a bad surgeon. But I think it also behooves us as surgeons trying to do the best thing for our patients to critically look at our technique and try to always optimize that.
It's interesting you say that, because one of your criticisms in the discussion was using bacterial cultures that they considered old. That they said old standards. Like, that was one of the discussion's points.
Well, we like say we've collaborated with David Greenberg who's a world-renowned microbiologist and infectious disease doctor, and we selected the bacterial strains that we thought best represented what we currently deal with. You know, there are certain standards that we do, and frankly, across cities, bacterial strains are different. So it's not really a valid criticism to say, well, use the wrong bacterial strains, because even across half a city, there's many different strains of bacteria, and there are different virulences, and certainly across states or countries or continents, they're huge. So it's just, you know, you have to pick what you think is best and go with that.
One of the things I wanted to talk to you about, especially because we have some of the younger surgeons on here, is let's talk about how you use irrigation, because I wouldn't want newer surgeons, younger surgeons mixing their triple antibiotic with their betadine, washing the pocket out and looking for bleeders. So give some advice to the younger generation. What's the best way to use this in the course of a case? Because I don't think we talk about that. You know, we talk about it, but it's important, you know, how you use it, when you use it. Is it the only irrigation you use? And what can we educate them on that?
Yeah, I mean, the key, and this is you'll see this in the paper. We discuss this in terms of your protocol or process for, just like there's a process of breast augmentation, there's a process for breast pocket preparation. So you want to dissect your pocket, you know, check everything, make sure that it's hemostatic. There's nothing more to do, and then you want to go through your process of preparing that pocket. So, you know, there's basically certain steps that we do the exact same way every time. But when it comes to, and the things such as, you know, we put Tegaderms over the nipples. I use chlorhexidine prep stick to re-prep the skin around where the implant's going to go. We rewash any instrument that's going to go into the pocket. What's key with the antimicrobial breast pocket irrigations is the two things. Remember, it's concentration and contact time that produces efficacy. So you don't want to dilute your antimicrobial breast pocket irrigation. That was one of the things that we found. The betadine containing irrigations, compared to everything else, had far better resistance to any kind of dilution. But when you use these things, there's ways to do it. So you don't just put in some of your antimicrobial breast pocket irrigation and then a bunch of saline, and all of a sudden you've just maybe you may have diluted it down to 1/10 of what the original concentration was. So you want to be careful about that. So the way we do that is we use 2 sequential 75 cc's of saline and evacuate that completely out. And then we do another 75 cc's of I use betadine triple or 50% betadine. And we instill that and evacuate that completely out. And then we do one final 75 cc's of betadine triple or 50% betadine and leave that in the pocket. So we don't irrigate it out. And then we place the implant. Some of the solution will come out, and then we close. And so I know from personal observation that I've seen that solution in the pocket for at least 18 hours. In this study, by 15 minutes, the first time point, it kills everything. So, but if you dilute it or you wash it out, you know, it depends on, you know, it may not work as well. The other thing to remember is that we actually have a second part of the study that we will be submitting to ASJ, and we hope the editors will hope to have them accept this chart. That looks at biofilm. This study looked at planktonic bacteria, so the free-floating bacteria. Certainly in primary breast surgery, that the biofilms don't form quick enough to be an issue during your surgery. It takes probably 6 hours, even for the fastest forming biofilms, are probably more like 24 for most of them to form. So this is for planktonic bacteria.
So the other thing, you know, we talk a lot about betadine being, you know, cidal, you know, bactericidal, but worrying about wound healing. And I've heard this forever, and I haven't seen it. Have you had wound healing problems? I mean, maybe we need to ask Dr. Nahai, but it's an issue we keep talking about. But unless you're soaking your incision constantly, which we do when there's an infection in it, but it's not an issue. You don't have to worry about that aspect of it.
Yeah, I mean, we have a lot of data. I've always used the betadine containing irrigations. You know, Bill Lineweaver was, I met him when I was at Stanford, and he was doing studies, and he published that even very low concentrations of betadine inhibited fibroblasts in culture. So that was one of the things when you know, there was this thing about betadine or iodine could affect the shell of the implant. That, I think, you mentioned that. that really was intraluminal. Somebody was filling saline implants
Exactly.
with betadine. There's never been any data, including a study I did with Leroy Young, looking at the shells of implants and testing those, that any extraluminal betadine has any detrimental effect on a breast implant. And then certainly we tried to have the lowest concentration and the most polymicrobial effect. And that's how we came up with betadine triple. But I see Tom Weiner on there. Tom's done, like I say, some fantastic studies with 50% betadine. I don't know if Tom wants to comment about wound healing things.
I do. So thanks, Bill. And Julie, yeah, I think you're absolutely correct that the ALCL, this has been, I actually asked Bill this a few months ago about ALCL. My concern was when the FDA banned betadine with no good reason whatsoever. As a matter of fact, the reasons were leading to patient harm. And, you know, I have a series of about 5 papers on betadine that I let everyone know my very obnoxious letters to the FDA, telling them I use betadine, please come and take my license if you think I'm wrong. And of course they wouldn't do it. That was my question to Bill, is did the FDA cause this rise in ALCL many, many years later? And I'm a conspiracy theorist, Bill knows this, and I think it's true. All right.
I agree.
I think it's true. So, but that aside, I also agree with Bill. Don't wash the betadine out. If you're washing it out, you're just cowering down to the old ban on betadine from the FDA, and it's not. It shouldn't be washed out. If you're washing it out, you're defeating the purpose of using it. There's no harm to the implant. I've been using this ever since I was in training with Tom Biggs, who taught me to use betadine. And then, of course, you know, my series of papers on betadine, and of course the incision paper about perirelar incision. You asked about wound healing problems, and this I think is one of the real keys that especially, well, actually many people overlook. There are 2 types of betadine that you need to be considering. There's betadine scrub and there's betadine paint. So betadine scrub is a detergent. And many people don't really think about this. So, you know, the nurse just squirts some betadine in the cup, you know, for the circulator, I mean, the circulator does for the scrub tech to use, and they don't really think about it. Don't use betadine scrub. It's a detergent. It will cause wound healing problems. Absolutely. All right.
And it's solution and detergent is the other definitions of them.
Correct. So what you want to use is what's called either betadine solution or betadine paint. That is the non-detergent version of it, and that's what you have to use, because it's not the betadine that has caused the wound healing problems in the past. It's the detergent fraction, and that's important to realize. Now, if you use 100% betadine, you know, the 10%, 100% of that without dilution, yeah, I think you'd probably get some wound healing problems, but we don't do that. That's why I use a 50% solution for betadine, and it's tremendously effective. You know, and let me jump ahead just for a second to the commentary that was posted on Bill's paper, and saying that there's no good, you know, long-term data showing that, you know, this is effective and all that. The long-term data is there. I've been doing this. You know, my practice is 26 years old, and I've been doing it for that long. If I get a patient that comes in after a breast augmentation, of course, I only use inframammary incisions. I don't have a problem with perireal incisions, but you know my paper on that. If I have a patient come in with capsular contracture, I'm shocked. All right. My incidence of capsular contracture is not 1%. It's way below 1%. So when Bill says that it reduces it 10%, and this commentary says there's no evidence it reduces it 10%, that's bullshit. In my experience, in my hands, it reduces it 10 times, it reduces it 20 times, it reduces it 30 times. So it's a dramatic improvement in contracture. And if it's doing so, whether it's betadine or, Bill's triple antibiotic or a combination, and there's obviously no harm. If there's harm being done, I guess all the patients I've harmed are just not telling me about it. But as soon as you have a problem with a patient, they will never get out of your hair. All right. So,
And that is such good advice for the young surgeons, because this is all about prevention. And to me, that's critical, because it's not only taking care of your patients, less risk to them, it's running your business.
right.
We're doing all of those things.
Yeah.
And let me tell you, you have a high capsular contracture rate, that costs your practice. And you just, like, I'm with you, Tom. If I see a cap con, I'm like, what the hell?
Yeah.
What is this?
Yeah.
Like, I don't like it. And I'm worried now that I'm using more smooth implants since 2016, that number is going to go up, because I felt that maybe my texture was helping me before, but it's been pretty well the same.
I've never used textured implants in my career. All right. So, and my capsular contracture rate is that low. I do subpectoral, but I don't think it's the placement that has a big effect. It's the betadine. But we're not promoting this, because we're making money from it. Bill and Julie, you and I are not stockholders in the
I
betadine
wish in
corporation.
betadine,
Yeah.
that would have been good. That
Yeah.
would have been a good one.
Exactly. So that's not it. But this is all about patient safety. Sorry about that. Let me drop that. So this is all about patient safety and doing the right thing for our patients. So you gotta listen to the science. You gotta listen to the data. What you said, or which Bill mentioned, that it's all about bacterial load. We're trying to reduce the bacterial load, just like coronavirus is all about viral load. All right, it's all the same thing.
You had to bring that up, Tom?
Exactly.
Yeah, that's like, we can't get into that.
Can't, like, for 5 minutes?
Julie, I completely agree with you and Tom, and I just want to make this comment too. Everything, advancement in our specialty, it's about prevention. Most of the time in surgery, how we advance the art and science of the surgery, is about learning things and then preventing these issues. Just like Julie and Tom have been saying, if you read the discussion of this paper, actually, they bring up at the end, they say, they think we should kind of quit talking about preventing ALCL and just start treating it, or talk about how advancing in treatments. And I completely disagree, because I think that the essence of high-level surgery is doing things to prevent that, and that's what this is all about.
Right.
It's like the old story about dead bodies coming down the river and learning how to deal with dead bodies, but never going upriver to figure out why were their dead bodies coming down. And to say that line actually really disturbed me a little bit, because I don't think we should ever think like that. We should always it should be concomitant at the same time. You should be talking about prevention, working about treatment, but to ever say you should ignore that, I don't think that's a very good statement to be said.
Well, it's not a good statement for the other reason that when a statement like that is made, just like we've seen some of our colleagues on social media promoting the on-block capsulectomy for breast implant illness, and what total nonsense. But don't propose something like that just because, well, you charge more money for a contracture, for a capsulectomy and implant exchange. So some people, that's where the money comes from. So this is not about making money. This is about patient safety.
Yeah, but I think the proof is in the pudding. So if you look at, this whole, we got into this regarding capsular contracture, not ALCL, and now it's obviously evolved that maybe ALCL is related to. I believe it clearly is related to some of these technique things as well. But capsular contracture rates 30 years ago were 30 to 50%, and now, as Tom said, it's not just these antimicrobial breast pocket irrigations, but that's part of the puzzle. It's other things that we do too, but we've reduced that. My capsular contracture rates are the same as Tom's. I think we have a series of over 20 years now that hopefully that'll be another thing we'll put in ASJ, but 0.1% is our capture contraction rate. So I do think that technique matters and prevention matters, and that's what it's all about for your patients.
Hey, Bill, can
And
I
I
say
think,
something? Hey,
oh,
hey, this is Brad.
Hey, Brad.
How are you guys? Hey, good to see you. Hey, I just want to remind everybody that, this is great to have this paper. I was really glad to see it get into the journal because there's so much conversation and discussion over the last couple of years. And some may remember in PRS last year, there was an article or a whole article about how antibiotic irrigation is nonsense by Swanson. And so Bill and I had done a letter to the editor, a response to that, let's say a response to that, talking about that, where Bill really, who knows it well, laid out all the details and all of the studies and all of the information to really confirm just antibiotic irrigation in general. We're talking about which one's the best, but just the idea. There's still this idea, people on the podium who are saying that maybe you don't need to do antibiotic irrigation. And I think for all of us just to have this go, no, actually, we actually do need to do all parts of the 14-point plan or, that kind of bacterial mitigation. And papers like this to help us understand which ones to do. Extremely, extremely important because we've been saying for a couple of years, betadine, but people still miss it. When I talk about it, it's like the first time, the audience often has heard it. So thank you for the article. It's really, really great. I was glad to see it. I did notice that you had sort of the idea at the end of the article, I remember reading it, which was that, well, if you're not allergic to antibiotics, then probably use the triple betadine. If you are, use the 50% betadine. The issue of fibroblasts and healing kind of came up a little bit, but I use 50% betadine, and I thought, well, too bad. I'm going to use my 50% betadine.
Yeah, I think like we talked about 20 years ago, there was these questions about healing and things. And so that was one of the reasons to look at things. How can we decrease the concentration of betadine? But I think that as you've heard, there's a lot of people that have had experience using, say, 50% betadine. And I would agree. And if it depends, I think using a betadine containing irrigation is what I would recommend. There's less steps. It's like baking a cake. So you got to put all the right ingredients, else the cake's going to taste bad. So you got to make sure whoever's mixing that, your operating room nurse, that they know, like, if they're going to do 50% of betadine, it's half and half saline and betadine. They can't just like put a little betadine and just whatever looks good. It's like a chemistry experiment. If they're going to do betadine triple, it's probably even a little bit more labor intensive. So you just have to make sure that if you want the simplest preparation, I think 50% betadine is a great irrigation. And actually 20 years ago, that was the same conclusion that we came to in our original paper.
So one of the things that I thought was interesting too, maybe you can comment on this, Dr. Adams, is the concept in the paper that you had this Ralstonia regrowth. So you knocked it down a little bit with some of the with the hypochlorous acid, the Irricep, the silver gel, but then actually as you followed it out to 18 hours, it grew back. What do you think was going on with that?
Well, I think part of again, that's why the science is so important. A lot of these different antiseptics like hypochlorous acid, Irricep, they're basically, number one, they're not even approved for things like breast pocket irrigation. They're called mechanical wound irrigation. So they're actually just like saline. They're approved for mechanical wound irrigation. The agent, whether it's hypochlorous acid or it's chlorhexidine, very dilute chlorhexidine, is in that solution in a very dilute form, basically to try to prevent bacteria in the bottle, like when it's on the shelf. But the problem is when we use it clinically, they get diluted no matter what you do. And so when you dilute those solutions, they don't work well. And that's what we found in the study. And I think that's why we felt like we were seeing bacterial regrowth, because they're just not, there's different effects. You can't put the same chlorhexidine that you prep a wound with in a wound. That's been shown to be very caustic. Hypochlorous acid is very oxidative, so you can't have a high concentration of hypochlorous acid. And so therefore, they're susceptible to dilution, which renders them not very good in terms of killing.
That's great to know. So maybe, Miriam, can we get a little update on some of the poll results that we had? And are there any questions from the attendees that you'd like to share?
Absolutely. So just going back to the polls, in terms of the irrigation solutions that our attendees are using, most of them are actually using the betadine and antibiotic solution combination, followed by using betadine, followed by antibiotic, and least common is the hypochlorous acid. We did have a few attendees who don't use anything or use saline only. So that's interesting to know about. And hopefully this will be a challenge our thinking a little bit. Of our attendees, you know, despite everything that went on with FDA a few years ago, the general consensus is that betadine is safe to use around implants, and the reasons that we're using antibiotic irrigation for implant related cases spans for all the causes that we talked about. So to prevent infections, capsular contracture, and to try and decrease the risk of BIA ALCL. And it seems like most of our attendees are looking at changing their practice based on the results of this paper. So that's interesting to know. A lot of them have had experience with textured implants before, but now going forward, I'm sure in light of everything that's going on with ALCL, they're using it very rarely and more case-by-case basis if needed. So that's the results of our polls. So very informative to know. Now, in terms of questions that have been coming up, a very interesting theme is around, you know, the hot new sexy thing, which is hypochlorous acid in phase 1. So I think that it would be really great if our author and discussant could comment on that, particularly maybe Dr. Adams, if you can just reiterate how, what your conclusions were in the study with regards to betadine as it compares to hypochlorous acid. There's been a lot of buzz around that in the recent year. So definitely our attendees want to know a bit more about that, and whether there's any difference between the different types of hypochlorous acid there is. You know, phase 1 is very well known, it's a popular one, but it is more costly than some of the other alternatives such as Purison Plus and Bosch, and what your opinion is on those products.
Yeah, well, as I alluded to, the problem with hypochlorous acid, phase 1, all of those different category is it's very dilute hypochlorous acid, and that's because of what I mentioned earlier, and therefore that just scientifically they don't test well compared to the betadine containing irrigation. So the betadine containing irrigations can be diluted manyfold and still have activity. The other thing that's of interest is in, this is not in this paper, but in another paper that's looked at hypochlorous acid solutions, they actually get inactivated with a protein soil test, which is kind of a standardized test that the FDA or TGA has all antiseptics go through. So there's some data out there that would indicate that it's probably wouldn't be the choice to use, especially given the fact that it's 10, 20 times more expensive than betadine.
Excellent, thank you. And then what's your opinion? You know, we did have at one of the previous ASJ journal clubs, we were discussing the efficacy of hypochlorous acid as being, you know, virucidal and helping with eradicate coronavirus. So there was some thought about using that just in light of the current environment. Not that, you know, we obviously don't have any literature out there that shows whether viral infections such as that have a role in implant related issues, but I think it's something that is on people's minds.
Yeah, well, we haven't certainly tested we haven't tested coronavirus against any of these things, but you know, I can tell you that I would predict that you're going to see the same thing again. It's a function of concentration and stability for dilution, but you know, betadine, povidone iodine it's bactericidal, it's fungicidal, it's virucidal. I am aware of a study on betadine. We have nothing to do with it, but it was for people gargling with it prior to ENT procedures, and they found that it was able to kill viruses in the oropharynx. And so, yeah, I mean, again, I just go back to the basic science. You know, if something doesn't test well in the lab, then it's probably not going to perform well clinically. And again, one of the points we made in this paper is that there's 25 to 30 years now of really good data from multiple people, multiple places globally around the world using betadine containing irrigations, and it's hard. It'll be hard to probably ever reproduce that with anything else, just given the success and efficacy of betadine containing irrigations.
And we just had
Yes,
another question here that says, what do you recommend if a patient's allergic to iodine? And also the offshoot of the patient who mentions the shellfish allergy. How does that tie into this?
Yeah, so those are, I'm going to add that to the urban legend list. The shellfish allergy, I've never seen anybody that has a so-called shellfish allergy have any issue with betadine. And again, in all the people that claim to be allergic, it's always I have a shellfish allergy, and then we can't use betadine. We've never seen that in a patient in 20 years. So we use it in people with shellfish allergies. So I've never seen anybody with any kind of allergic issue to betadine. Now, if you're using, say, betadine triple, so you have cefazolin and gentamicin, obviously, then you can remove those and just go with 50% betadine. If somebody has a cephalosporin allergy or they've got an aminoglycoside allergy.
Hey, Bill, one comment on that. When someone writes down that they're allergic to iodine, I always ask them specifically what they mean, because almost 100% what they mean is iodine contrast. The same thing when they write shellfish allergy, it's iodine contrast. There is no cross-reactivity between iodine contrast and betadine. It's a completely different chemical. So if they're iodine contrast allergic, you can use betadine.
And I've done that too with a little skin test, just to prove it to them.
Yeah.
When they say, no, when you hear the story, it doesn't really make sense. I'm just going to pull a prep here. If it reacts, we won't use it in surgery next week or in 2 months.
The other thing you can ask, if they've had previous surgery, you ask them, have you had betadine prep or that brown prep? You say, oh yeah, I had it, no problem. But you're iodine contrast allergic. It's no big deal. There is no cross reactivity. Don't worry about it.
That's great. Well, listen, as soon as I read this paper, I knew that I wanted to discuss it in this forum. I thought it was fantastic science, looking at an important topic. And, looking at the poll results, 67% of the respondents say that they would consider changing their implant pocket irrigation solution based on the results. So, I'd like to thank you, Dr. Adams, all of your co-authors, for putting in the time, and for you for coming on here tonight, for Dr. Khanna for coming on tonight, for everybody tuning in tonight. I appreciate it all. And thank you, Phaedra, for sharing in anticipation.
Good luck on Friday, Ryan.
Girl or boy, we don't know.
Congratulations. Find out.
Why didn't we do a poll?
We should have. I know, we talked about it. Is it too late?
A poll.
Hang on a second. We still have 69 people on. Let's do a poll. So what we find out is Ryan having a boy or a girl. And earlier we talked about letting the people decide. So I think everyone can get in on this.
It's science.
There you go. It's science. Let's see if we're right. You'll have to let us know.
I will. I will update you on Instagram and on the next Journal Club.
Ryan, I'm gonna have Jamil buy you some cleansing nails for me. So it'll be for the new one. It'll be full throttle though.
Can't wait. Thank you so much.
Okay, here we go. Okay, so
this comes out 50.
Girls in the lead with 48%. Nope, boy, 53%. Ryan, you're going to have to bring these stats back to your wife and circle back and let us know how we did here.
I know.
There's a coin flip.
Ooh, 51-49.
Wow.
Is that the distribution of males and females on this call?
Yeah. No. You and I both know, Bill, that's not true.
There we go. It's a boy.
Still not enough girls here yet.
It's a boy. It's official.
Well,
There you go.
with that poll, we're starting to lose some of our followers. So I think that's the natural end of tonight's Journal Club. So Dr. Adams, thank you so much. Dr. Khanna, thank you so much. Everybody who
Thank you guys.
took some time, thank you so much.
It was great. Appreciate
Tune
it.
in next month for the YAPS Journal Club. Tune in 2 months for the NGE Journal Club. We'll all see you then.